All righty. Well, hello. Welcome, folks, to the first installment of the YWCA Stand Against Racism series. We've been gone for a little while, but are excited to be back. And so thank you for joining us today. As you know, the YWCA is dedicated to eliminating racism, empowering women, and promoting peace, justice, freedom, and dignity for all. And it's our hope that in these Stand Against Racism webinars that you actually come with questions, get them answered, and then leave really compelled to do the next thing in your sphere of influence. And so today we're really excited to have Dr. Tameka Blake here with us, and we will be talking about just some things that center around health disparities. And it's fantastic because we know that we are talking about the right things when there's synergy. And last night, the city council of Green Bay voted to sign on to the state declaration of racism as a health crisis. And so the timing of this couldn't be better. Just to get us started, I wanted to just tell you a little bit about Dr. Blake. She joins us, and she is originally from Brooklyn, New York, and in 2001, she attended Cornell University, graduating cum laude with a Bachelor of Arts degree in chemistry. Later, she graduated from Weill Cornell Medical School in New York in 2006. And then she actually is a board certified emergency physician practicing in Metro Atlanta. She owns 2 Jamaican franchise locations of Krust Caribbean Restaurant, located right in the southeast of Atlanta. And she's been featured as a medical expert on Personal Injury Court, Rolling Out Magazine, and Hope TV. Tameka is married with 3 children, ages 9, 10, and 18, and she enjoys traveling and spending quality time with her family. Dr. Blake, thank you so much for being with us today. I just wanted to share the definition of health disparity before you get started. So a health disparity refers to a higher burden of illness, injury, disability, or mortality experienced by one group relative to another. And healthcare disparity typically refers to differences between groups in healthcare insurance coverage, access to and use of care, and the quality of care that they experience. And so thank you again for joining us today in this really important discussion, Dr. Blake.
Hi, good day, everyone. I'm so excited to be here, and it is a pleasure and an honor to be speaking to everyone on this forum on such an important topic, healthcare disparities. And during this recent time, we've all discovered that, there are inherent biases and really things that have affected multiple areas of our society, and healthcare is no exception. And I always feel it's important to talk about the story, because there's always a story and there's so much power in the story. So I actually wanted to share with you a personal story of mine that relates to, how this conversation of healthcare disparities come about. So my mom, who was a healthcare provider, she was a nurse. She's no longer with us. She passed a few years ago. Many years ago, she went to a hospital. She immigrated from Jamaica, originally from Jamaica, West Indies. And when she came here for the American dream. She went to school and wanted to do better for herself and her family. And at some point in the late 70s, she became ill. She went to the local county hospital in Brooklyn, and they did all these tests, and they discovered that she had a problem with her gallbladder. Mm-hmm. Now, she was told she had gallstones and she needed to have her gallbladder out. Now, this was the late 70s, and at the time, going to hospital then, if they told you needed surgery, that was not something in our community that we were fond of. It was like, no one's cutting on me. There was definitely an even more profound lack of trust when it came to the medical community. So she said, no, doc, because the issue was, there was a chance, like, if I go in to have the surgery, I may not come out. That was what was something we had to grapple with. I wasn't born at the time. It was a year before I was born. So she said, doc, give me some antibiotics. I'm going home. Fast forward 30 years later, she's not feeling well. She goes to seek help, and figure out what's going on. Now she's been a nurse for 30 years and what have you. And I'm like, this is not no regular stomach virus. You need to get this checked out. Turns out it's her gallbladder. Now, throughout my life, I had never heard of her having an issue with the gallbladder. This comes up 30 plus years later. So, I mean, having an issue with her gallbladder. Of course, she had a gallbladder. So she went back to the hospital. This time, they're like, you know, you need your gallbladder out. When she gets her gallbladder out, no complication, the pathology report comes back as cancer. Now, the risk factor for getting gallbladder cancer, which is a very rare disease, rare cancer, is one of the rarer cancers, is gallstones. Now, due to her lack of trust of the medical system, if she had gotten her gallbladder out many years ago, the likelihood of her having gallbladder and actually succumbing to the disease, she battled it for 3 years, and it is one of the more deadly cancers, and she passed away from it. So that's just a personal story I share with you in terms of how someone in medicine, a person of color, may look at the medical system, and there's an inherent mistrust because of the concern for bias against her getting that surgery. Now, I wanted to touch on some points of just going to the root of why there is healthcare disparities in this country.
Mm-hmm.
So why was there a mistrust? It came from somewhere. It didn't happen overnight. So if you go back to the early 1930s, there is a very popular study, the Tuskegee syphilis study. And that came out of in Alabama, a historically Black college, where they went to recruit people to get treated, African Americans, for bad blood. And it was a United States public health study. So it wasn't like this was something that was approved and said, we're going to study Black people for bad blood. And what they were actually looking at was those who were contracting the disease syphilis. And what they did was they were telling the participants to study, like they would get free access to medical care and that they would be treated and all these great things. And they're like, oh, great, sign me up. And what they were doing was really treating those who potentially had syphilis and studying them. Now, 15 years later into the study, there's a drug called penicillin, which is a very common drug, which they found out treated syphilis. And guess what? They did not stop the study. Black people who were diagnosed with syphilis were not given the treatment. They were given placebo, meaning they weren't given any treatment at all. And they went home, men went home and gave it to their wives. There were babies being born with congenital syphilis. And this went on for almost 40 years. I mean, look it up. It's in the books. This is our history. And I will tell you, when it comes to healthcare disparities, first point, we have to be aware. We have to acknowledge. I believe in 1997, at the time Bill Clinton was the president, he publicly apologized and acknowledged the suffering for all those who went through that actual study. So if you look back, and that's, this is the 1900s, it wasn't that long ago. Mm-hmm. So when you look back, like, where is this coming from? Why is there some lack of trust? Because already as a person of color, you're thinking you're not going to get the better care because there was a case. We have documented evidence where that happened. This happened in the United States of America. Additionally, something that I discovered in medicine, in my training as a physician, the way we look at the kidney function. And this is something that has been, from the beginning of time, all the medical books. So how we look at someone's ability to their kidney to work correctly is blood work. So one of the blood work that comes back from the kidney function is something called a GFR. Now that's an estimated result that they get, a calculation of how the kidney works. If you look at the lab result, you'll see where it says African American and non-African American. So they separated out I mean, if anyone get their blood work now, you have portals, you can look at it. That is something that has been from the beginning of time reported. This is how physicians look at blood work. And based on your color of your skin, your kidney function has this estimation. Now, it's been said that muscle mass is greater in African Americans, and which is why this calculation is what it is. But there have been over a decade of work showing that this is an issue. There's an implicit bias when we're doing patients looking at their kidney. And what it's led to is if you're an African American and you have severe kidney disease and potentially needs a transplant, this calculation decreases your risk of getting a transplant. And African Americans already are less likely to get a transplant from a kidney. And right now, as of late, because we're looking at healthcare disparities, we're looking at racism in multiple areas of society. Now, I think the journal JAMA, Medical Association Journal, came out with something and really making petitions to actually change that laboratory result, because we're now discovering it has an inherent racism. What if you are biracial and you're like, well, I have a Black parent and a white parent. Like, where do I fall? You know, which result do I look at?
Right.
We should not be reporting that. Another thing that came up was the nervous system. So how we are treated in terms of pain medicine in the medical textbooks, it was basically taught that Black people had different nerve endings than their counterparts. So it was basically said that they had thicker skin. So if you went in, say you had the worst pain of your life, you were given less pain medicine. That's what it comes out to, right? Where did that information come from? You know, this is what was being taught to the ones that are going to be caring for African Americans. You know, and even though that's not in the current textbooks, you can see how that implicit inherent bias has carried over for years, where to this day there are studies showing if you have even in kids, a child that suffers an injury and is treated in a medical facility, and you have a Black child versus a Caucasian child, the Black child's gonna be given less pain medicine for their issue. So there is definitely data to support that this has been happening, and there's a difference. Another thing I want to look at is dermatology. The textbooks, all of the textbooks I remember looking at as an emergency physician, sometimes you're going to encounter rashes, skin illnesses that we need to be able to identify. 99% of those textbooks show Caucasian rashes. So how can I identify a Black person who has shingles, which is a very painful rash, right? If we can even have enough information to study so that you can diagnose that person, right? There's not even, I believe now they're looking at having textbooks that show rashes of patients of color, because a rash on one person is going to look different on certain pigmentation than another. Indeed. And they can be, and even though most rashes are not deadly, there are some that you have to be able to identify that could be life-threatening. So it's multiple areas. And then additionally, looking at women, right? So already, particularly for women in heart disease, and when it comes to women versus men, women are more likely to have what they call atypical symptoms. So we're talking about heart attacks. So, and there's been all these studies looking at, so the person who comes with a heart attack, they'll say something's sitting on my chest. Women, we think it's indigestion, you know, we think it's all these other things. I just got gas or whatever. And they're like at home dying with a heart attack. And they're like, it's my stomach, but they're pointing to their chest. So it's just, they have nausea, vomiting, all these atypical symptoms. what the data has shown, and even the American Heart Association, they've come out and said that if, basically there are some inequities when it comes to race in regards to heart disease. And if you are a person of color, you're more likely to die of a heart attack than a Caucasian. And what it is there are social determinants of health, right?
Mm-hmm.
So if you have less access to care,
Mm-hmm.
if you are living in, so the how you're born, like into this country, where you live, where you work and grow, if you live in a place where, for example, you're not feeling an unsafe neighborhood and it's 3 a.m. and you're worried about if you are below the poverty line going to get an ambulance to, get your heart checked out, they'll stay home and delay their care. And by the time you get to the hospital, that is, with a heart attack, time is of the essence.
Right.
So by the time you get to the hospital, you've suffered damage to the heart muscle that may be irreversible.
Mm-hmm.
And that's how they're more likely to die from the disease, because they'll have the complications such as congestive heart failure and all of those things. Additionally, for stroke, my leg's not working. Oh, I just slept wrong, and they may not seek care because they're worried about cost. Even I look at, what's going on now with COVID, there's a huge childcare crisis that we have not even begun to grapple with. And there are young mothers who may have medical problems that are, they're having to choose between, well, I got my kids to watch. I don't have time to go and seek care, where there are other ethnicities that may have, they may have things in place to be able to care for their children so they can seek adequate health care. So there's so many different parts that need to be addressed. Now, looking at maternal health in particular, so we already have what I think is a higher maternal health related complication rate in our country, which of late has decreased. But when you look at African American women, they're 3 times more likely to have a maternal complication that may lead to death. And what I've heard, just even patients that I've treated and spoken to, and they said, no one listens to me. Like, you're the first person that listened to me. It's almost like, having a baby is so precious, right? Imagine, having a baby and something's going wrong, right? And you're screaming at the top of your lungs, like, I know something's not right. And no one's believing you.
Yeah, and you know what, Dr. Blake, and that was what now? So we have the most celebrated tennis player in the world, and when she was in having a baby, she had exactly that experience. She had had the illness before, and she told doctors that she knew what it was, and they didn't listen. She basically had to kick and scream before they responded to her. That's a perfect example of that.
And I'm so glad you brought up Serena, because she is the perfect example. So that means all the money in the world,
right?
It didn't matter, right? All the status, the elitists, she's they call her the GOAT, the greatest of all time, as my son would say. And even in still, she had to like kick and scream to say something's wrong with me.
Right.
And that's why have been so fired up, really, of what I can do as a physician of color. Right now, Black female physicians only make up 2% of the medicine community. And I will tell you that we as physicians, Black men and women, but particularly women, we're having to deal with the other part, even in us trying to inform our communities, where we're being told, are you a doctor? Right? They're still trying to grapple with, should I trust what she's saying to me? You
Mm-hmm.
know, recently I had a talk with one of my colleagues, and I had to say, well, we don't know who to trust, right? And I'm like, just because I don't walk around with something stamped on my forehead saying I went to Cornell Medical School like Dr. Fauci, like, what is it going to take for you to believe that I care? Because at the end of the day, you know, every person of color, that could be my mother, my brother, my sister, my cousin, my husband, my child. And, you know, there was something I actually just came across this article literally today. It said Black newborns 3 times more likely to die when looked after by white doctors. Literally, as in 1:09 p.m. today, Eastern Time from CNN.
Mm-hmm. Wow.
And it's just, I'm like, how is that happening? And
Mm-hmm.
what they actually looked at was that Caucasian babies, if they had a Black or white doctor, they fared better still.
Mm-hmm. Well, in Wisconsin, an African American baby is less likely to be born at healthy weight and less likely to live to the age of 1 than an African American baby born in any other state of the Union. And so you are bringing up some issues that when you center them against the backdrop of some of the racism that's happening across the state of Wisconsin, that says that people of color are faring even worse than the average person of color in the United States because something is going on in the state of Wisconsin. And so I appreciate you saying, you know, like, so Dr. Fauci, people recognize him. He went to Cornell University, and so you went to the same medical college that he went to, but because of your presentation as a person of color, as a Black woman, people are less likely to believe you. And I think that what hasn't happened is people haven't come to the understanding that then is why this stress and some of those other health disparities exist around people who actually haven't been believed, they haven't been listened to, they haven't been trusted, they haven't been all of these different things. And it has affected the quality of their lives, but it has also affected determinants of health that make them live less long. And so we shared some statistics just the other day, and people were staggered by them. In Brown County, which is where the YWCA is located, white citizens live on average 18 years longer than Hispanic citizens.
Mm.
They live 16 years longer than Black citizens. And so you keep going down the racial list, and actually it's clearly a disparate opportunity in terms of just life expectancy. And so something is going on in the quality of life experiences that people in Brown County, in broader Green Bay, and in the state of Wisconsin. And so thank you for all of that information. I had a couple of other statistics that I wanted to share, but I wanted to go to the reality of oral health because people don't think about oral health much. But as an emergency physician, you know that you often have patients present in the ER for dental issues that
Yes.
basically weren't caught. And so there was some startling statistics when I tried to do my preparation for this. And I was just like, I have to say something about this. And so first of all, for those with private insurance, Wisconsin recently ranked #1 in overall dental health and access. Those are for those that have private insurance. But for the underinsured, so that's children, sometimes, oftentimes, Wisconsin consistently is placed amongst the lowest for access and dental health measures. Wisconsin has had the lowest medical reimbursement rates in the nation for several years, and less than 1% of Wisconsin's Medicaid spending is actually used for dental care. So,
Wow.
over 41,000 emergency room visits from preventable dental conditions happen in Wisconsin, and over 50% of that is paid by Medicaid. And so when you start seeing things totally out of whack, you recognize that one thing builds upon the other and it's all connected. What are your thoughts about dental, oral hygiene, and medical room visits, Dr. Blake?
We see it all the time, and it's the ones who don't have access to care, right? And we are like, when it comes to dental care in the emergency room, we are a Band-Aid station. Like
Mm.
if you are having to get admitted or stay in the hospital for a dental emergency, it is serious, right?
Right.
Because there is a severe illness called Ludwig's angina, where you have this like increased swelling that goes all the way into that space underneath your jaw, where it can actually affect your airway. If it's gotten that bad, it's awful, you know. But ultimately, all we do is give something for the pain and antibiotics. And I say, well, you really need to follow up with a dentist. And what happens is those that have access to care. So if say, you know, you have a dental issue, you come in during off hours and the dentist is not open, they get that treatment right away. And they're like, yes, doc, I'm going to the dentist on Monday. What happens if you have no dentist? What happens if you work at the local retail store or supermarket? Not every employer gives dental insurance.
Right. Right.
So what happens is that infection continues, and you know, you fare worse if you have other medical problems.
Mhm.
Like if you're a diabetic and you have an infection, those two things do not go together. That's
Mhm.
going to make you have, it's going to, your blood glucose is going to be up, uncontrolled. What happens when, it's like a domino effect. What
Right.
happens when your uncontrolled diabetes with the dental abscess issue continues? Your
Mhm.
kidneys, dental can, you know, have all these issues with your sugar. And then if your glucose stays uncontrolled and as a diabetic for long periods of time, that can affect your kidneys. That's why in African American communities, we have such high rates of end-stage renal disease and that we're on dialysis.
Wow. Yeah.
So it all comes together. One does not go without the other.
Right. Right. And when you talk about you referring your patients to dentists in Wisconsin, 2/3 of our dentists do not accept Medicaid. So
So
you just referred a patient to their dentist, and they have a dentist in the area that they have access to, and they don't accept Medicaid, so they're still without dental access. And those are the kind of things that go into this kind of a big picture of health disparities, right? And people don't think much about it, and they haven't given serious thought to things like we don't have a transportation system that allows a family without a car to get on the bus to go to a dental visit that is 45 minutes, an hour and a half away, or in the next city, because none of the providers in their area actually accept the Medicaid that is their primary insurance, right? And so all of
correct.
those things really are absolutely just these um, complexities stopped on top of each other, right? Well,
Mhm.
and the other thing that we know is there are hundreds of studies, thousands of studies that actually have linked racism to worse health outcomes. So it's not
Yes.
something that's made up. People have been researching it, and there is evidence that said this you just named several things.
Yeah.
Because this patient is a black, a brown, a red, a person of color, and it shows up immediately on their health records, it is the chances of them having the same experience as a person that is white is diminished right away. Wow.
Exactly. And like
Wow.
even looking at, you know, even if you have access to care and then you get treatment, what happens if that drug is an expensive drug that's not covered by Medicaid and that's your source of health care?
Right.
And it's the one drug you need for your regular heart rate. And it
Right.
works perfectly for you. Like if you take this drug, everything is pretty much controlled and you can have a good quality life.
Mm-hmm. But your Medicaid doesn't cover it, or
And
Medicaid
that happens all the
all the
time,
time. Mm-hmm. Mm-hmm.
you know, and they're having to, and forget about those young women with children that have to choose between the diabetic drug and putting food on their table,
Mm-hmm. Mm-hmm.
and
Mm-hmm.
blood pressure medicine and bus money to get to school. You know, now a lot of people are virtual, but there are so many aspects that affect their ability to care for themselves. So then
Right.
you say, well, how could it be that someone a person of color is more likely to die from a heart attack? I just told you. There's multiple reasons.
Right. Well, and then you talk about poverty. If we pull out poverty, let's listen to the statistics in Green Bay about poverty. In 2018, the Green Bay and Brown County census data showed us that 11% of white citizens live in poverty. So 11%. 72% of Pacific Islanders in Green Bay live in poverty. 46% of Black in Green Bay live in poverty.
Wow.
33% of Native Americans who live in Green Bay live in poverty. And 23% of our Hispanic neighbors live in poverty. And so if Medicaid, which is what most impoverished individuals or low resource people have as their medical insurance, what chance do they have to get the best medical response to their issue? It's pretty slim, right?
Exactly. And and some doctors don't even accept Medicaid.
Right. So
For some, I've heard I can't find a doctor, it's like every step. Because I believe one thing I want to really make clear, Black people and other persons of color, I believe, because I've cared for them, want the best for themselves. They want good health care. They want to be well. Like, I haven't even delved into the idea of a food desert, right? Growing up in Brooklyn, and now as I've gotten older, it's something I didn't even realize. Like, I would go to the bodega, and what we drank as a child, I mean, there was these drinks where it was like 50-cent sodas, 20 ounces. And I like a tropical fantasy. They got a different name in every state, right? That was what we drank because it was cheap.
Right.
Diet Coke, I never saw Diet Coke in my bodega. What was that? There are places in our country where communities of color can't have access to nutritious food.
Right.
So how do you say as a doctor, you need to eat right? You need to exercise. You need to take your medicines with you don't even have access to get produce.
Right. Or the expense of it becomes the limitation, right?
And then if you're living in an impoverished area, eating healthy is expensive.
It is very expensive. I just had this conversation about the farmers market here. The farmers market has fantastic food, but you know what? It's not for low resource people because they can't afford it. And so people don't recognize it, then that becomes another barrier. Dr. Blake, I have a question in our chat box that I'd like to ask of you. And so our respondent asks, how can non-medical professionals support and impact systemic change in the healthcare system?
That is such an important point. So it starts from the beginning. I think ultimately there are medical schools where, in most states, where they are training the doctors who are going to care for me when I'm older, and most of us, right? Writing a letter saying, hey, what are you doing as the medical school in my state to train the young medical professionals on the inherent implicit biases in medicine to decrease healthcare disparities and decrease having lower outcomes? What are you is there a task force? How are you making sure that what are you doing to increase the diversity in your medical school? So that you'll have more physicians that actually look like their patients. I just read the article where there were Black babies were more likely to live if they had a Black doctor. When as a physician, you take an oath, a Hippocratic oath to do no harm. And ultimately, I'm not saying that other ethnicity doctor who took care of a patient inherently decided to, I'm gonna, do harm to this baby, but we have to acknowledge there is something wrong here, right? The data is telling us that there's a problem, right? So
Right.
kudos to the state of Wisconsin or making sure that we understand that it's a public health care crisis.
Right.
It's not okay for babies of color to die at higher rates than white babies.
Right.
That's not okay in this country.
And so some of the current research in Wisconsin says that Black women are up to 4 times more likely to die of pregnancy-related complications than white women. That's in 2020.
Oh my gosh.
4 times.
2020. I mean, we have to be advocates.
Mm-hmm.
We have to be advocates. We have to sign petitions. What are you doing to make sure we're confident? It is no longer okay. And it was never okay. And I will tell you, you know, a lot of my colleagues who are like Black women, female physicians, as well as Black men, we've known this all along.
Mm-hmm.
Because at the end of the day, if I go like soccer mom to the store, we've all had that experience where we got looked at differently, where someone may be trailing behind us. We were
Mm-hmm.
treated differently. There was a disparity. And
Mm-hmm.
how much money in my bank account did not matter.
Mm-hmm.
You know, I have a 18-year-old college freshman who I've had, due to all the police brutality, I've had to have some really frank conversations with.
Indeed.
And when he was driving my car the night before he moved into his freshman apartment off campus housing, he was stopped by the police.
Mm-hmm.
And thank God he fared well and he was fine. But what if he had made the wrong move?
Right.
And to this day, I don't even know why he got stopped. The only thing I can tell him, he was driving my Mercedes truck, and I cannot. I mean, I said, well, he said, Mom, I wasn't speeding. He came home so scared, literally wanted to wet his pants. There are differences in how we treat it, and in medicine, there's been no exception. So I feel like it's my responsibility to speak up and make as many people aware that I can.
Mm-hmm, mm-hmm, mm-hmm. So we need to do some work in the state of Wisconsin. So Dr. Blake, first of all, thank you so much for your service. And I really am sorry that your son had that experience. I have 2, they're adult sons now, but we could go down the list of the number of times that they have been stopped and had reversals as a result of that. But back to the infant mortality, to the conversation of infants. So we talk about people or humans who actually are vulnerable. What can be more vulnerable than an infant, right? Wisconsin, we actually have the highest rate of infant mortality for infants of non-Hispanic Black women is the highest in the nation in Wisconsin. So we have the highest rate of infant mortality in 2020 in the nation, the whole United States. No babies fare worse in infant mortality than in Wisconsin.
I mean, that's so startling. And all it takes, majority of time, it starts before the baby's born.
Mm-hmm.
Are women in Wisconsin, in communities of color, getting access to medical care? Are they having prenatal care? Because the majority of issues that come up with newborns being born most likely could have had an intervention during pregnancy. So it starts with the mother.
Right, indeed. Mm-hmm. Mm-hmm. So we've been talking a lot of doom and gloom. Let me give us a couple of highlights, right? So the YWCA in Green Bay is actually partnering with Encompass Solutions, and it is a nonprofit in Milwaukee that focuses on high-risk pregnancies and mothers who actually are at risk for problem pregnancies. And so our relationship or the conversations that we're in would provide us access with care providers who come in and actually go into the homes of mothers who are at high risk.
Mm.
And so we've been in conversations because we've been paying attention to the data, and we've been saying, okay, those are some things that we can do. In Green Bay, the YWCA was just awarded a grant by the Brown County Health Department, and we are going to be undertaking focus group interviews of 5 different minority populations, asking them what has their experience been accessing care here in Green Bay, because I think the data doesn't lie. And so we will have interviewers that are representative of their particular background, and that should eliminate a little bit of the interviewer bias. And we're just trying to help the community to get it right. We have caring people in the community, and some of the things are happening because they don't know that they're happening. And so we're through these Stand Against Racism events, our Where We Learn series, No Wrong Thing, we are talking about really tough things, and we're giving people information, and we are inviting them to just do something. Right. And so, yes, absolutely. If we had prenatal visits, we would have caught some of these things. But women, Black women in Wisconsin, I think it's 50%. They are 50% less likely to have prenatal visits in the first trimester than white women.
I mean, the proof is in the pudding. I mean, like you said, the data doesn't lie.
Right.
So
and
we can't be shocked when we see, like, oh my God, babies died.
Right. Well,
did they get to the doctor when they were
right.
pregnant? You know, it's like they all are connected.
Well, Dr. Blake, but think back to why your mom didn't want to have her gallbladder out. That inherent mistrust, like all of this is connected. If you feel bad about yourself when you go to the doctor, you're not going back. If you go to a healthcare professional and you don't feel good about yourself because of the interaction, you're not going back. You just figure it out, right?
Yeah.
And so I think that we need to talk more about those things. I actually today had a great conversation with Oral Health Partners of Green Bay, and we will be doing some training. They have elected to have our diversity and equity specialists here in town do some training so that their nurses, their hygienists, their doctors have an understanding that they basically have an opportunity to change a person's life because they're sitting in their dental chair, right? And so it's about the services that are being provided, but it is also about the spirit that the services are provided in. And when you make a patient that's afraid in your chair feel like they matter, they will come back. They will brush their teeth more. They will floss. They will do some things that actually determine the quality of oral hygiene that they have. And it's just a little big thing, right?
Yes. You know, you're touching on so many important points. As a patient, you should feel treated with respect.
Mm-hmm, mm-hmm.
And you touch on, I've heard patients say, like, they didn't listen to me. You know, I just felt like they brushed me off, or they didn't. And I've been trying to educate Black people, saying it's okay to ask questions.
Right.
Like, doctor means teacher. It's not okay for you to leave. Like, you know, I've heard of patients going to the emergency room where they came out and they can't tell you what was done to them. I mean, they were there for 5 hours. They had tests done. It's okay to say, doctor, why are you doing this test? What are you looking for? What did my blood work show? And they're supposed to answer those questions. So it starts with, you have to be advocate for yourself. Like Sabrina was screaming, like, something's wrong with me. You need to know what was done. Is there a way you can explain to me what's going on? And if you don't feel like you're getting the answers, step it up. Is there a patient advocate? Is there someone else I can speak with? You know, I feel that that's such a key. If you feel respected, if you feel that you're getting the care, like someone cares, right? You walk in the room and I remember one of the best patient compliments I had was, are you going to be my doctor? And I was like, no, I believe the other doctor we can for you. And they said, you just seem like a nice doctor. And I was like, well, I haven't cared for you yet. How do you know? it's just how, you just have that demeanor, right?
That's nice. It is.
You know, I want patients that I care for to have that feeling, because you know what? They may listen to me.
Right.
They may do, they're like, man, that doctor, I think she was trying to do the best for me. I'm going to
Right.
go home and take my medicine. I
Mhm.
understand that I have asthma and I shouldn't be smoking. I want to do right. I want to do this for me. She made me understand that if I don't do this, I could have chronic lung disease, or if I don't do this, I could have kidney disease or a heart attack.
Right. Right. Yeah, and see, you're pointing to some of the psychology. I am not a psychologist, but I do know energy, right? And so you're pointing to the fact that if a person has an interaction with you and the energy was positive, the likelihood of them responding in a positive way is increased exponentially. And so what we know is that if people of color are feeling afraid or startled, your brain shuts off for most people when they're afraid, right? And so you're in an interaction with a doctor and you're feeling smaller and smaller and smaller, where you're not going
Yeah.
to remember half of the things they said to you because you were trying to protect yourself while you were trying to be supported in the doctor's office. And I think that that's a little big thing. Like when
Yeah.
people feel safe, they listen differently. They remember differently. When people feel safe, they feel inspired actually to do hard stuff. Like I'm fond of saying that you can do anything with friends. If you have an interaction with a doctor or dentist and they feel like your friend, you are going to
Mm.
be able to do some things differently after that interaction than you would if you felt hostility or if you felt shame. Like, or they looked through you and you didn't matter. It is going to have an impact on what you are going to be able to do as a patient. Do we have others? Um, so thank you. Thank you so much for your service, Dr. Blake. Like you have touched on so many fantastic questions. And I think they're little things that we just are not in the habit of thinking about. I mean, because the whole idea of just existing in a culture or in an environment where people don't think you matter, it is impactful to your health.
I mean, you said it. It's our lives matter.
Yeah.
And as when you're seeking medical care, you have to make sure as a patient that you let them know. And I
Uh-huh.
will tell you, there are patients that bring that bad experience that someone had in their family, and they bring it to them for the rest of their life. I've had patients that said, I haven't been to the doctor in 10 years. And I'm like, why not? And they're like, my mom came to this, institution, or she had a bad experience and I don't trust doctors.
Right. That's
And
significant.
it is. Then you wonder why there's a healthcare disparities. We're still dealing with trust.
Right. Yeah. Like you shouldn't, like there is a certain level of, and for lack of a better word, trauma when you are being cut into, right? Like if you're having surgery, that's a certain level of trauma that happens just because you are having surgery. Like you don't want to complexify that with the trauma of racism, so you doubly traumatized,
Yeah.
so there is the trauma associated with the harm that has to be caused because you got to harm them to help them on some level, right? You got to cut in
Yeah.
and get the poison out of the thing that's infected. So that's a certain level of trauma, but let's not complexify the possibility of healing with additional trauma that actually can be remediated if people just go in and treat the people like they would like to be treated. Treat the people like the people that you love, right?
Yeah.
Um, yeah, and so, I'm 53 years old and I have a family that I'm a part of. We are fortunately healthy people, but I can tell you some of the experiences that we have that have made us feel like, I'm not sure if I want to go back there. And like you said, well, people should know. Well, even if you tell them, that doesn't make it easy to do. If public speaking is the number, if people are more afraid of public speaking than
Mm.
several other less impactful things. People that feel scared are not going to speak up for themselves. They just aren't going to do it. There's no training for, speak up for yourself in the doctor's office 101. We
That's
don't
true.
really do those trainings, right? And so, but we know that safety increases the capacity to speak up. And so
Exactly.
safety, yeah, we can just treat each other kindly. We can treat each other like the way we want to be treated. It goes a long way for creating a space for people to be able to have better outcomes. Dr. Blake, we have just a couple of minutes left.
Okay.
No, we actually have how many? 10? We have 10 minutes left. And so if you had to give one piece of advice to individuals in the community who happen to be people of color about what they could do to make their emergency room visit better or have better outcomes with their emergency room visit, what would that be?
So one thing that I've seen, because we're scared, particularly during this time of COVID, do not wait to access care. Every emergency room in this country, they cannot turn you away. There's a law called the EMTALA, the Emergency Medical Active Labor Treatment Act. So if you need care, do not wait to the last minute, because particularly during COVID, what I've seen is that because we're so scared of it, we've waited to the very end. So by the time someone may have respiratory or problems breathing, they could end up on a ventilator. So that's one thing I definitely want to really impart in our communities. Do not delay access.
Mm-hmm.
And I know it's hard to trust. And there have been many instances where you look at these numbers and it's frightening, like, oh, how can I trust anyone with my health if you're telling me that my healthcare outcome is going to be less? So what you can do, particularly for those who have medical problems, we have these smartphones. Everybody has smartphones. Put it in your notes. Put down your medical problems. Write it down. If it's diabetes, high blood pressure, just have a little area. Sometimes they have a health app where you could put down what your medical issues are, the medicines you're taking. You don't have to be able to pronounce it. Just write it down word for word. Look at the bottle, right? Because this is what we need to better care for you. And you're like, here, nurse, I got my list, and here's my medical issues. So having whatever information you have, and another part we always seem to forget, our family history. If every sibling and your mother and father had a heart attack at 40, that's important to know. That puts you at a higher risk. So guess what? If you're a 45-year-old female with upper stomach pain, there's really a chest, you should be getting tests to look at your heart when you're in the emergency room. So having information is key. And if ever you're in a space where you're feeling not safe, you feel that you're not being listened to, find someone in that healthcare institution that will listen. You ask for an advocate, like, you mentioned public speaking and it's hard to speak up. There's someone in that institution that is there to speak up for patients. You find them and you're like, look, I'm concerned. I feel I have been dismissed. I feel like I have not been listened to. Something's wrong with me. What else can be done? It is okay to ask questions.
Wow. Thank you for that. And so the coronavirus conversation is distinctly different than just the normal conversation. So what we know is that the death rate of people of color, in particular Black Americans, is a huge, significantly different level than every other American in the country. Do you have anything to say about that? What's going on with that? You touched on a little bit when you were talking about access to good food, when you talked about poverty, and we certainly have raised the issue of health determinants. You want to say anything else about that?
So everything about COVID has basically highlighted that's always been there. Disparities has always been there in our communities. what COVID did was highlighted. So if you have someone who has medical problems, their diabetes, hypertension, obesity, and that can all be related to social determinants of health, COVID has shown that you are more likely to disproportionately succumb to disease, like die from it. Because if you're healthy, more likely to recover. So these medical problems complicate it and exacerbates COVID, and that's why we have seen a higher rate of death. So if we're getting access sooner, if we're able to get medicines, get to doctors, right? And you're in a subset of category where you're controlled medical problems, you're less likely to succumb to the disease. So all COVID did was highlight all the issues that's been there all along, but it put it on such a blast, which is why we're having the conversation we're having.
Excellent, thank you. You know, there are a lot of things that we have no control over, Dr. Blake, but there are a few that we have some control over. Exercise is one of those things that we have control over. And we actually run a fitness facility here, and we have a couple of things that are fantastic. We have swimming lessons that actually are said to be the best in town. And so we invite you all to consider the YWCA for swimming lessons, for our aerobics classes, and other fitness things. Would you mind saying a little bit about the benefit of just moving your body?
I'm so glad you spoke of that. Fitness is my zen. You know, and I'm not a size 0, but after I had kids, I was like, I need to work out. It's my peace. It does so much for you mentally, physically. It gives you energy. There are people who are walking around saying, I'm always so tired, right? Start exercising. You know, it helps with, I've had patients who said that I'm not taking a blood pressure medicine because I've lost all this weight and I've been eating healthier and exercising. It helps you do better with these illnesses that come, that may or may not come. So during COVID, I know everyone's like, well, how can I exercise? I can't get out. Get up early, put your mask on, go during a time when it's least likely to have people outside because you're worried about social distancing, and start walking, start moving. It does not have to be an indoor gym, you know, so working out, there's so many benefits. So I've heard questions about, well, should I be taking an immune booster? Exercise is the immune booster. Like, no, this is so key. Overall wellness. Like, now is the time. If you ever wanted to be well, this is the perfect time, because I will tell you, I believe they're doing more studies, but obesity definitely is a high risk when it comes to COVID.
Wow.
You know, and this is because you're like, well, there are a few people, they're like, well, why did this person, they didn't have any medical problems. And a lot of them, when you're looking at, they were obese. That was their only issue. So now is a great time to exercise and really get out there. And if you're still afraid and say, well, I don't live in an area where it's safe enough to go outside, where there's more people moving around and you can't social distance, YouTube, like, there are all these at-home workout videos, and a lot of the national fitness organizations, I know, like, I go to Orange Theory, they were doing at-home workouts. Planet, they have these videos where you can just work out in your house.
Indeed.
So absolutely, exercise, wellness during this time, drinking plenty of water, getting your rest is so key.
Excellent, very great, thank you. And so we know that exercising your body is great, but exercising your mind is also great. And so we have a lot of things to think about here at the YWCA. So we invite you to visit our website often. Our commitment is to dedication to eliminating racism, empowering women, promoting peace, justice, freedom, and dignity for all. And we want to do that by really giving you good content to be chewing on. We have a website that has references. And so if you're looking for good things to read, if you're looking for things to serve to kind of up your IQ about the things that contribute to health disparities, visit our website. This is a time right now where if you want to be educated about anything in the world. It's just a finger click away. And so we want to give Dr. Blake a round of applause for being here today. Thank you so much, Dr. Blake. Thank you for your kind spirit and for the service that you give and you provide. Congratulations on this phase of your next thing in terms of your book project and all of the things that you're doing in Atlanta. And so we hope to have you back with us another time. And so thank you so very much for being with us today.
Thank you. It's been a pleasure and an honor. And just kudos to the YWCA for what they're doing and their stand against racism. I'm so excited, and just congratulations to all of you.
Thank you so much. And so you all, we have the next Stand Against Racism is on September 16th, and it is Racism and COVID, the Asian community. So please, thank you for spending your time with us today, and we look forward to seeing you again then. All right, thanks again, Dr. Blake. Have a good one.
Bye.
All right, bye-bye.